Bismillah ar-Rahman ar-Rahim. First of all, I would like to thank the organizing committee of this very respected conference, and especially special thanks to Professor Dr. Nadia, the pioneer in this field, and she gives us the motivation to work in this field. I will talk about different patterns of muscle affection by whole body muscle MRI and their significance. Skeletal muscle diseases are a broad and diverse group of disorders, and the clinical presentation of these disorders may be quite similar, creating a need for an ancillary testing. The approach for diagnosis and treatment requires an integrated approach that merges clinical, imaging, electrodiagnostic, pathologic, and genetic data, and this is makes the need for a group of multidisciplinary team to work together to each in his field or in his specialty, given his participation in the diagnosis and management of these diseases. Imaging studies such as ultrasound and MRI can accurately depict alteration in muscle structure and help in narrowing the differential diagnosis. MRI is particularly well suited for evaluation of both deep and superficial muscles and offers an excellent contrast between healthy and diseased tissues. Myopathy or muscle disease encompasses both hereditary and acquired disorders of muscles typically present with muscle weakness. Hereditary myopathies can present at any age from birth or early childhood throughout late adulthood. Acquired myopathies such as polymyositis and dermatomyositis commonly present with insidious progressive proximal symmetrical weakness with elevated CPK level. The signal characteristics of MRI are based upon the interaction between magnetic forces and the composition of tissues. T1 sequences are good for detecting fat deposition in chronic myopathies, while T2 sequences, especially with suppression of fat signal, such as STAIR sequence, are the preferred sequence for visualizing acute or subacute muscle changes related to edema. To start with the normal appearance of skeletal muscles by MRI, usually when we do whole body muscle MRI, we depend on three sequences. The first is T1 weighted sequence, which this one is the first image, and the T2 weighted sequence without fat suppression, and the STAIR or T2 weighted fat suppressed sequence. The normal muscles appear of intermediate signal lower than that of subcutaneous fat. This is the subcutaneous fat in T1, and in T2 sequences, the muscles appear intermediate signal lower than that of fat, while in fat suppressed sequences such as STAIR, it is slightly higher than the subcutaneous fat because it contains some water, but it is slightly higher than that of subcutaneous fat. One of the advantages of MRI that can image the patient in different planes, axial or sagittal or coronal, either by true imaging or by reformatted images. After we image, we can image the patient in axial images, then we reformat the images into coronal or sagittal or any plane we want. If we look to fatty infiltration of skeletal muscles, what is its appearance by MRI? Also, this is the same consequences, T1, T2, and STAIR. In T1, the muscles with fat infiltration appears of high signal, slightly lower than that of subcutaneous fat. This is also in T2 weighted images. The fat within the muscle is a higher signal, slightly lower than that of subcutaneous fat, while in STAIR or fat suppressed images, the signal turns into low signal, similar to that of subcutaneous fat. This means this is the fat infiltration of the muscle. Edema, which usually occurs in acute or subacute stages. In T1 weighted images, looks normal. This muscle, the adductor muscle, looks normal by T1 weighted images, while in T2 weighted images, it shows higher signal, but it's similar to that of the fat, intermuscular fat, yet in fat suppressed sequences, and this is the advantage of this sequence, it is very bright due to edema in the muscle, very well appreciated by fat suppressed sequence. This muscle is edematous. Usually the situation in muscle diseases is a combination of fatty infiltration and edema, not a single pathology. So how can we detect it, both of them in the same patient? Start with the fatty infiltration. This is the lead. This is the soleus muscle by T1 high signal, by T2 high signal, but by stir or fat suppressed sequence it turns into low signal. While the anterior group of muscle, and namely the extensor hallucis, it is more or less normal with T1, slightly high with T2, and bright with stir signal denoting edema. So in this patient, both muscle fatty infiltration and muscle edema coexist. This is the different stages of muscle affection by the same disease. When we ask about patterns of muscle involvement, what do we mean by pattern? Many questions concerned with this pattern. We can talk about is unilateral or bilateral affection. The affection is unilateral or bilateral, and if it is bilateral, is it symmetrical, nearly symmetrical, or completely asymmetrical? This is one look for the pattern. Another look, and this is an example of unilateral affection. This is the glutei, the gluteus medius and the minimus muscles in the right side is affected, while in the left side it looks normal. This is unilateral affection. This is bilateral symmetrical affection of the thigh and leg muscles. Coronal image typically is the same in both sides. Bilateral nearly symmetrical. If we look to the extensor, to the semitendinosus muscle on the left side, it looks more or less nearly normal, yet in the right side it is affected. But other muscles, such as quadriceps, is nearly the same between the two sides. So it is symmetrical, but nearly symmetrical, not typically symmetrical. Another look for the pattern, is it proximal more than distal, distal or distal than proximal? If the lower limb is affected more than the upper limb, or the reverse upper limb is more affected, or it is a non-specific pattern. This is an example. This is the thigh. First image, this is the thigh, and this is the leg. In the thigh, the quadriceps is markedly affected. Also, the hamstring muscles are affected, but to lesser extent, while the leg looks more or less normal. So this pattern is more proximal. Affection is proximal more than the leg is less affected than the thigh. Another example, this is the T1 weighted image for the pelvic girdle. This is the affection of the gluteal muscles, while the shoulder girdle is completely normal. This means that the lower limb is affected more than the upper limb. Another way to look for the pattern, to look for the most affected muscles and the spared muscle. Which muscles are most affected and which is the spared muscles? This is an example. This is all images, T1 images for the shoulder girdle. This is the subscapularis muscle is mostly affected, while the other muscles are completely normal. This is mild affection of the subscapularis muscle with mild affection of the deltoid, and the other muscles are spared. This is the affection of the deltoid and the infraspinatus muscle, but the subscapularis and the infraspinatus muscle, but subscapularis is more affected than those. This if we talk about the whole muscles, many muscles. But if we look inside a single muscle, is this a pattern within a single muscle? Can we detect and help us to diagnose or narrow the differential diagnosis of muscle affection? If we look to the muscle affection, is the affected muscle, we can look if the pattern is proximal more than distal within the muscle. The proximal part of the muscle is affected more than the distal, or the reverse, or the central part of the muscle is more affected than its periphery or the reverse, the medial part of the muscle is affected more, its lateral part or the reverse, or there is no or special pattern with special signs and we'll show, or the pattern is non-specific within the muscle. These are examples of the affection of the sartorius of the gracilis muscle. This is reformatted sagittal image. The proximal part of the gracilis muscle is much affected, while its distal part is more or less normal. And this is the corresponding axial image. This is at the proximal part. The sartorius gracilis muscle is affected, definitely affected, while its distal part is much spared. Specific patterns of muscle affection. If we look to the deltoid in figure A, granular pattern of affection. The affection is granular. In figure B, the erector spinae muscle, its lateral part is much more affected than its medial part. Also, this is a granular part of affection of gracilis and sartorius in figure C. And if we look to this sign in the rectus femoris muscle, which is called the target sign or ring sign, and the pattern of affection in the soleus muscle is striated muscle. Each muscle is affected in a different pattern, in different shape by MRI. And also we can look for other organs than the skeletal muscles, help us in the diagnosis and narrow the differential diagnosis of such diseases, such as the brain. Different patterns of brain involvement in these diseases can be present, such as white matter abnormalities and cysts, brachygyra and lissencephaly, cerebellar atrophy and cysts, pontine hypoplasia and tertium thickening. As an example, in figure A and B, this is hypomyelination of the white matter with sparing of the corpus callosum and the internal capsule. In figure C, thin corpus callosum and atrophic vermis and flat bones. D and E, also thin corpus callosum, hypomyelination and microgyra of the frontal area with atrophic bones and atrophic vermis. In figure F, abnormal bones, abnormal shape of the bones, and small cysts in the cerebellum, in the right cerebellar hemisphere. Different patterns, each pattern can occur in different diseases, help us to diagnose which specific disease is that. I will give only 2 examples of different specific patterns in specific diseases. To start with late onset Pompe disease. It is a rare autosomal recessive disease caused by mutations in the gene that encodes for lysosomal enzyme acid alpha glucosidase, leading to accumulation of glycogen within the lysosomes of the cells in multiple tissues, including skeletal, cardiac, and smooth muscles. 2 main clinical phenotypes are described: classical infantile onset Pompe disease and late onset Pompe disease. To talk about infantile onset, it results from an almost complete deficiency of acid alpha glucosidase and is clinically characterized by onset of symptoms soon after birth with hypotonia, generalized muscle weakness, and cardiomyopathy, leading to death in the first year of life if untreated. While the late onset is characterized by onset later in life with a clinical picture of slowly progressive proximal muscle weakness associated with respiratory muscle involvement. What is the pattern of muscle affection in late onset Pompe disease? It is bilateral, nearly symmetrical, as shown by these images. The tongue muscles nearly the same in both sides. The chest wall muscles, the serratus anterior, also same affected in both sides. The latissimus dorsi muscles in both sides are also almost the same or nearly the same affected. Also the hamstring muscles and in both sides nearly the same. The erector spinae muscle are also affected, and the glutei affection of the gluteus medius and minimus with sparing of gluteus maximus. This is a specific pattern for this disease. The most affected muscles are the tongue muscles, substabularis, serratus anterior, latissimus dorsi, paraspinal muscles or erectorospinal muscle, gluteus medius and minimus, as we said, with sparing of the gluteus maximus muscle and the adductor magnus and long head of biceps femoris muscles. Tongue muscles involvement is a characteristic pattern in late onset Bombay disease and only differential diagnosed with sarcoglycanopathies. Leg muscles usually spared or affected less than thigh muscles, means proximal than distal, with differential diagnosis of dystrophinopathies and dysferlinopathies and calvinopathies. Absence of signal abnormality in stare due to absence of muscle edema, differential diagnosis with dysferlinopathies and facioscapulohumeral muscular dystrophy. Another example is myosin deficient congenital muscular dystrophy. Is an autosomal recessive form of muscular dystrophy characterized by muscle weakness apparent at birth or in the first 6 months of life. Patients show hypotonia, poor suckling and cry, and delayed motor development. Most never achieve independent ambulation. Most patients also have periventricular white matter abnormalities on brain imaging, but mental retardation and or seizures occur only rarely. The specific pattern of muscle affection in myosin deficient muscular dystrophy is bilateral nearly symmetrical muscle involvement. The most affected muscles are substabularis, paraspinal muscles, gluteal mainly gluteus maximus, in contrast to the late onset Bombay disease. Thigh mainly quadriceps, also in contrast to the Bombay disease late onset, which affect mainly the hamstring muscles, and cuff mainly the posterior compartment, also in contrast to late onset Bombay disease, which usually the leg is spared or affected only lately. The diagram shows the most affected muscles in red color and the most and the spared muscles in blue color, and the red one for the most affected muscles. There is specific patterns of involvement in muscle involvement in myosin deficient muscular dystrophies. We mentioned before the granular pattern in deltoid and in gracilis and sartorius, the striated pattern in soleus, the lateral then medial in erectorospinae, and the ring design in rectus femoris muscles. If we do MRI brain, both T2 weighted images and stare, in most of the cases of myosin deficient muscular dystrophy, there is periventricular hypomyelination characteristic, but usually the no mental retardation or seizures present only in few cases. The key point, imaging of the skeletal muscles is an essential part in diagnosis of muscle diseases. Whole body muscle MRI is a powerful imaging tool, can detect pattern of muscle affection as well as the affection of other organs such as the brain, as we mentioned. Identifying the patterns of muscle affection plus or minus affection of other organs helps in narrowing of the differential diagnosis and in guidance of the further step in workup. Thank you.
Thank you very much.